Hello, everyone. Welcome to the Wednesday Zoominar with myself and Dr. Perry Carpenter. Thank you, Dr. Carpenter, for organizing this and having me on your show. Much appreciated. I'm going to be talking about imaging findings of permanent impairment today. My name is Cliff Tao, and I'm a chiropractic radiologist in Orange County, California. I imagine all of you are from California and probably recognize this area here. This is in Orange County, specifically in Huntington Beach, and I love this picture because it shows the beach. Incidentally, my friend, a chiropractor, Louis Rice, is surfing here. His practice is in Huntington, or in Costa Mesa actually, but he lives in Huntington Beach. And on this particular day, you can see snow-capped mountains in the background. So there's not many places in the world, I think, where you can enjoy both the mountains and the surf and sand on the same day. Here's perhaps a better picture of me. This is on Halloween a couple years ago in our town of Irvine in Orange County. This is my wife, Angela, dressed up as Black Widow. My son at the time liked Spider-Man. Of course, now he doesn't want anything to do with Spider-Man. And myself as the Hulk. So today is going to be fairly quick. I'm going to do a quick intro just on the format of images that I think is better for doing our permanent impairments. It'll be relatively quick. And then we'll go into, what I think, we all call the Bible, those of us that use these permanent impairments, and specifically looking at chapters 15, 16, and 17 on the spine, wrist, and arthritis on our evaluations. So part of imaging acquisition, I know it's really hard sometimes to get good images, even if it's in your own practice. And but the big thing for me, and I think for probably all radiologists, is that the format of the images must be in DICOM format. If you've heard of the word DICOM, it does get thrown around a lot, and I think its widespread use can lead to a lot of confusion. There's these websites. This one's called DICOM Solutions. Incidentally, I think it's a local, or used to be kind of a local company, but they sell X-ray equipment and software. And then there's another one, which sometimes we actually use this. It's called DICOM Store, and it's used to transmit small images, not small images, but once in a blue moon types of imaging studies to various providers. But DICOM is a trademark term, and it stands for Digital Imaging and Communication in Medicine, and it provides a universal, international at least, a standard for medical images. And it has anything to do with medical images, DICOM has a standard for it. So it goes from anywhere from production of the image to transmitting or sending the images, how to even display the images. They have standards on what types of monitors you have specific to the imaging modality, how you're supposed to store, if you, too many people that print them now, and how to process these images too. So it's a fairly robust set of standards. I think they need to be updated, and I think it could be a lot better, but that's all we have out there in terms of a well-accepted standard out there. And all diagnostic images are in this format. If you have your own X-ray or other imaging modality on site, you should be very familiar with the format. And you really have to have it in order to do a good job in terms of measuring things and evaluating anything to do with a diagnostic image. It's easy if you have your own X-ray. It's very easy to get the images and start measuring from there and evaluating the image. It's pretty easy from a CD, and I can show you how to do that. If you use an imaging center that doesn't do CDs anymore, because now they're seen as expensive and they take a lot of time to produce. It can be done from a portal, but sometimes it's impossible. Sometimes the imaging center just does not have that capability. They don't have the software that has that option, or they didn't pay for that particular option to be able to download the DICOM images. I'll introduce to you this particular software. It's called Radiant or Radiant. I don't know how to say it, but I use it all the time. I'd probably say at least half of the DACBRs use it. Probably 100% of the recent DACBRs use it. And it's just like it says here. It's smart to use it. It's easy, and it's super fast to use it. I've been using it for over a decade. And I actually used a free version for several years, and finally broke down and paid for the paid version. The paid version is only $160, and it has the exact same functionalities as the free version. The only downfall with the free version is that it makes you wait about 30 seconds before you open up an image, which doesn't sound like a lot of time, but when you're looking at 50 images a day or 50 studies a day, it can definitely slow you down. There's also a banner that kind of shows up on your images that can kind of get in the way, but there's ways around it, and I'll show you that as we go through our slides today. There's a lot of benefits in using the same viewer. So I try to use this on any outside imaging we have and on certain types of imaging that we receive on our regular platforms. And I don't think I need to go through this, but it's so nice just to know 2 or 3 programs where you know exactly which buttons do what function. And so you're not monkeying around trying to figure out, which button does what and what functions are there and which functions are not. Just in terms of time efficiency. So I really don't know too many disadvantages of using a nice, intuitive, and consistent program. So here's the website. I'll try to post a link in this while you're listening to this, so you have it right at your fingertips. But it's radiantviewer.com. I love it. So chapter 15 is on the spine, and specifically the subsection 15.1b. You're probably all familiar with this, but it says, whenever possible, the physician should personally review these imaging studies and report whether you agree or disagree with the prior interpretation or with the primary report. I know Dr. Carpenter has mentioned this in the past. That is, part of your report that you should incorporate. And specifically what we're going to be talking about today in the spine is motion segment integrity. And this can only be really determined on x-rays. Motion of the individual spine segments cannot be determined by physical exam, but is evaluated with flexion, extension, Röntgenograms. I don't really like the term Röntgenograms, but of course that, refers to our father of radiology and really of all diagnostic imaging, William Röntgen, which incidentally today, March 27th, is his birthday. But anyway, so yeah, you need flexion extension radiographs. If you're taking them yourself or if you're ordering them, there's certain advantages and disadvantages of either process. But in either case, you should have a table like this. I love tables myself. It just kind of makes everything very clear and unambiguous. And so where you can document where the flexion measurements are, extension measurements, then the difference that you get here, normal reference range, and whether it's normal or abnormal motion segment integrity. So this, if you're familiar with these, I hope you are. These I have a little disclaimer here. The positive measurements are ones where you measure in the segments are in kyphosis and negative in lordosis. And this is kind of a no-brainer, I guess, but I've seen a lot of mistakes happen, and it really leaves your head scratching when you really think something should be abnormal and it shows up as normal, or the other way around. So it is very important to do these, and I'll explain a little bit more about that later. There's also this secondary part which you can do too, where you're comparing the motion segment integrity between the segments. And so you can use these to determine the integrity of the motion segments. Another table you can have has to do with translational measurements. So this is a more, kind of a quote unquote basic way. And we do these routinely on our flexion extension radiographs, whether they are, QME or PI or whatever, we just do them routinely if we have that in our practice. And this is a more simple table. You just, note the anterolisthesis, which is positive, and if it's retrolisthesis, then you note it as negative. You calculate the difference, and then it's either normal or it's abnormal, meaning it's unstable, or there's a loss of motion segment integrity. So here's an example I'm going to show you. These are flexion extension x-rays, and I'm just going to pause here for a second so I can switch over to our DICOM viewer, the Radiant DICOM viewer. So here's a window I have open with a bunch of studies in there. You can see all these down here, and this one up here are all compressed folders, and I've put all the files, the DICOM files in there, and you can see all I do is I right mouse click and I select open with Radiant DICOM viewer, and it pops open like this. And so this is just how we do it multiple times a day. And since we're just doing a flexion extension, I'll just put the flexion here. You just drag and drop them over here. If I'm doing measurements, I tend to like blowing them up as quickly as I can, and you'll notice as I'm blowing them up, I'll even show you can change, of course, the contrast and the density, what we call windowing. You can pan through it, zoom in and out, and you can do basic measurements fairly easily. You do have to have a nice mouse associated with it, meaning you have to have the thumb buttons. If you want to look on your mouse, you should have these thumb buttons. It really helps because those buttons are all pre-programmed with default values, and they're all the default values that I use, every day in our radiology practice. So there's no need to mess around typically with all the functions up here. And there's hundreds of different, maybe not hundreds, but a lot of functions up there that you can use. Today we do have to click one of these things, and so we're going to click the Cobb measurement angle. So let's go up here, and you can see there's all these different types of measurements you can do. So let's select Cobb. And Cobb, as you know, is typically used for measuring scoliosis, a coronal plane abnormality. But the way they measure it is, you have two lines that are not connected typically, and it works perfectly for doing these flexion extension ones. So the way you do these is, you have to be able to identify the plane of the inferior cortical end plate. So fairly easy. I like to do it a little bit longer, just so it's easy for me to, okay, this is, too much, this is too little, I want to be right on the cortex like that. And the next line you draw would be down here. So we're just doing C2, 3 right now, too much, too little, let's do it right on the border right there. And you can see, as I'm going through there, you can see the angle change as I'm doing it, and it puts that dotted line there so you can see whether immediately if it's a lordosis or a kyphosis. Sometimes, when it's less than or around 1 degree, it's really hard to tell, but you can just look up here and it'll tell you, because this won't give you the positive or negative. They're always absolute values when you're measuring them here. I forgot we should measure our measurement up here, so let's do this between C1 and 2, so it's right through the axis of C1, and that will be compared with the inferior cortical end plate of C2. And I'm just going to, at best eyeball a parallel line with the line I already have there. And look at that. So then now we have a kyphotic angle of 30.2 degrees. So I'm just going to move these so I know which one we're talking about. So this is between C1 and 2. This is going to be between C2 and 3. And let's do between 3 and 4. So here I draw another line that's parallel with the inferior end plate of C3, inferior end plate of C4. I get 9.8. Let's go between 4 and 5. Another parallel line. Again, just eyeballing, and but doing the best we can, between 4 and 5, so we get about 4.2. Let's move that down here, move this down here. Let's go between 5 and 6, another parallel line, approximately parallel. And you can toggle back and forth. I'll show you what I mean with that later. Here, is it here? This one, is it down here? I think it's probably about here, so let's do that. And it looks like it's 0 degrees, so not a great example. And for our final one, between 6 and 7, so here is, oh, what did I do here? I think I messed it up. Oh, I did mess it up. I think let me just pause here for a second. Okay, so I deleted those, and let's redo these. So let's go between C5 and C6. So what I meant earlier was, you can go, oh, and that's too, what is that? Too lordotic, too kyphotic. Let's go right in the middle, right about there. So that's C5. Go to inferior plate of C6. Let's go about here. We get 3.7 or so. Let's go between C7 and T1. Let's see, that looks too much. This is too little. Let's go right there. And I don't know why it keeps doing that. Okay, I think I double clicked and it put 2 lines in there when it was only supposed to be 1. So here's another parallel line there at C7, or 3, 4, 5, 6 at 6, and then here a parallel line at C7, and I'm only getting about not very much, 0.3 degree difference there. And then I do the same thing here on the extension view. And if you want it even bigger, you can double click on the image you want, and it can do it as one image versus 2 panels like this. So I'll just do these very quickly. Oh, you know what? I should probably bring this down a little bit like that. It's fairly simple. So that's just the angle between, and this is a lordotic angle, right? And usually between C1 and 2, it is always maintains a lordotic angle. We know there's not much flexion extension that happens there. So that's between C1 and C2. We go between C2 and C3, and we just work our way down. So you can see here at C2-3, it looks like a kyphotic angle of 2.5 degrees. And so let me just go back to the PowerPoint slide here. And so you should come up with something like this in the end. And well, you can see the numbers here are actually very small, but you can make them bigger. So here you can make them bigger, and if you want to provide these pictures within your report, it's very easy to copy them and then insert into your report. Just makes it, I think, more defensible. So you plop those into your table that you already have. These aren't going to be the exact same numbers that I just showed you, but I think they're pretty close. So here you can see at C1-2, 4.8 degrees of total angular motion. I got 28.2, and then 33 degrees, both lordotic measurements. And so when you add them, you're just calculating the difference between them. For you math wizards, you might think, oh, is it better just to use absolute numbers? It is in most cases, but sometimes it isn't, because you may have a kyphosis in extension, and then that'll mess up your measurement. So you really do have to record your measurements. Just like I say here, if they're in kyphosis, they should be positive. If they're lordotic, then it should be negative. Their normal reference range is noted as little, which, I don't like it because it's not objective, but what's little? Probably less than 5 degrees or something like that. I'd consider that normal. At C2-3, the guides say, about 10 degrees is normal there. That's about 10 degrees, 11.4. So I say that's normal. And then they say it goes up to about 20 degrees at C5-6 and C6/7. They don't really say what's at C3-4 and C4-5. So I kind of just, divide this into thirds. And so I come up with about 11 to 15 degrees at 3-4. Okay, that's normal because we got 14.2. I come up with about 15 to 19 degrees at C4-5. Okay, 8.6, that's almost half of 15. So it's probably a decreased motion segment integrity. And then definitely decreased at these lower levels, C5-6 and C6/7, right? 7.8 degrees here, definitely less than 20. 3.7 degrees, definitely less than 20 degrees here. Just for fun, you can kind of look at the numbers and tell this won't be, come up with any positive numbers, or not positive, but any useful numbers for impairment rating. You can calculate the difference between 4.8 and 11.4. Okay, that's only 6.6, and so on. And you need at least 11 degrees of a change or difference between two levels in order to have a loss of motion segment integrity. Here's the other way that you can measure. If you have flexion extension views, you can measure the antero and retrolistheses. And so it's the same way to measure it. You just have to have the appropriate function selected. And I can show you actually really quickly right now. If I go back to the program, and we can delete all of these. You just go up here and let's say edit measurements, delete all visible panels. Now they're all gone. And then you want to go back up here. And there's shortcuts for all these. So we want to measure length, which is L. So I'm not even I didn't select it yet, but if I hit L on my computer here, and you'll notice up here, it's probably a little bit hard to see. Let me see if I can blow it up here for you. So here, look at up here. Oop, it's my little magnifying tool here. So if you look up here, you can see it. Well, actually, it's so this is a picture of a mouse here that you can see. If the yellow square there means that the left mouse button is now selected to do the length measurement. But you can see that this middle bar is purple, which means it's selected, and that's your distal thumb button. So that also will do the length measurement. So typically that's not the default function. The normally default function when you open the program is that the distal thumb button will measure. So I'm going to use a distal thumb button. I know you can't tell me, but this is distal thumb button, and this is the left mouse button. So just to test, they both are doing that function right now. So let's go to C3-4, and actually this is would be a nice exercise to do because sometimes we don't know where to draw our lines from. And here at 3-4, you can just eyeball it and say, oh, that's probably a retrolisthesis, but how far? Do we measure from here? That this posterior cortex here. Do we measure from here? There's another cortical edge here, or somewhere in between. And the reason why we have these, of course, is because we have the transverse process, or the TP, two TPs, right, on the left and right side that we're looking through right here. And so it gets very confusing, and it does highlight the importance of having high quality X-rays. And so that's one of the advantages of getting an outside facility to do them, because mostly outside facilities, imaging centers, and hospitals have much better X-ray machines than are typically within the average chiropractic office. So I would probably, look at this. I'd like to look at the lower border to see where the posterior corner is, because sometimes that's better defined, and kind of see where a reasonable area would be to draw the retrolisthesis. And there's two ways to measure the retrolisthesis. So one way is like I showed you with the L or linear measurement. So if I use my distal thumb button, or now selected my left mouse button, I'll measure it like this. And you want to measure this at about parallel, or it should be, parallel to the superior end plate. And then, kind of imagine another line that is perpendicular to the line you drew. So if I just go like this, that line should point right at the corner of the posterior or inferior corner of the vertebra above. So I get about 2.5 millimeters here. And so that's in extension, right? So this would be a negative measurement that we jot down. So remember that, 2.5. And let's do the same measurement here using the same landmarks, right? So it almost doesn't matter where you pick your posterior superior border from, but I think the more important thing is to keep it a consistent landmark going from flexion to extension. So let's do C3-4 at this point. And, and sometimes it's very difficult because its flexion and extension views weren't taken exactly in the lateral projection. Patients move, they may flex or lateral flex a little more, and you won't have the same landmarks. But I think it's about here, right? You can see a little bit of lucency there. Let me window it a little bit better so you can see. So there's a lucency here. This is probably the posterior cortical border of the TPs. And then back here is probably the posterior border of the vertebral body. But either case, right, it doesn't really matter. I'm going to use what I think is the same landmark that I used on my extension view, and now draw it this way. So again, this should be parallel to the end plate. So it's about here. And then you can kind of eyeball, or let me move this out of the way. Again, think of a line that's about perpendicular, and that's how you determine the anterior limit of your line that you just drew. So that's, here, why did I choose this? Well, I try to figure out where the approximate corner would be, or not even approximate. I've tried to find out exactly where it is. Where would these two lines, if I extended these, where would they converge? So I think it's about here. So I get 0.8. So if we go back to our table here, I don't remember what I had. Oh, so it's close to what I had. minus 2.7, right? That's what we got in extension, and 0.9 millimeters. That's kind of close to what I got in flexion. And you add these numbers, right? Or what's the difference? You subtract the negative number, so you end up adding it, and you get 3.6, which is greater than the normal reference range. So this is actually an increase in the normal motion segment integrity. And then you incorporate that into your QME report. Okay, so now we're on to the upper extremities, and more specifically for carpal instability. So this is under chapter 16, and more specifically under subsection 16.7a under bone and joint deformities. And under carpal instability, it's really just a measurement of these 5 key things: radiolunate angle, scapholunate angle, scapholunate gap. My pointer is going weird here. The triquetral-lunate step-off, and ulnar translation. The one that's most common is the scapholunate gap. We learned it in school, right, as the scapholunate interval, or if you remember the Terry Thomas sign, or I believe some of us called it the David Letterman sign. Most of us didn't know who Terry Thomas was. But those two individuals have a split front tooth, right? And that refers to the increased gap between the scaphoid and the lunate. Normally it should be about 1.5 to 2 millimeters. If it's more than that, then it suggests that there's some type of dissociation there. According to the AMA guidelines, 5th edition, they set the cutoff at 3 millimeters. As you can see here on the table, the third one is scapholunate gap, 3 millimeters. So you do miss some, or I believe a significant number if it's at 3 millimeters. I mean, we've even seen people with scapholunate instability with normal scapholunate joints, less than 1.5 millimeters. You'll notice here under the table it says in an asterisk, clenched fist with neutral P to A views, and that's important. When you clench your fist, it drives the capitate more proximal, and it drives it into the scaphoid and the lunate. So if there's any kind of laxity of the scapholunate ligament, or if it really is torn, it will separate the scaphoid and the lunate. And you do that both. Actually, it doesn't say here, but I think it says this in the description in the subsection 16.7 that you should do it both for the P to A and the lateral view for the same reason. It will separate the scaphoid and the lunate, but it also, if there's any separation, there may be tilting of the lunate anteriorly or posteriorly, and so it's a much more sensitive exam. You can also just do the wrist view in the A to P projection, and that would be about the same. But I think the preferred way is to do it P to A with the clenched fist and in a 10 to 15 degree pronated position. And that's because the scapholunate joint is at about 10 or 15 degrees, so it makes the measurement much more accurate, and again, a more sensitive exam. So here's a blow-up of the table with how you measure the first 2 measurements at least with this line drawing on the lateral view, and I'll show you how to draw those lines. But it's 3 basic lines through the radius, through the scaphoid, and through the lunate. So I'm just going to bring over a study I have here that's just directly from our cloud-based viewer. And this is just another view. It's called Purview. It works just as well as Radiant. Actually, I like Radiant better, but this has we're able to connect this directly to various offices and directly to the X-ray machines. And so if someone wants to send over an X-ray, it really just takes a couple clicks, and then we have it within a couple minutes. So it makes that process very easy. Anyway, so these are 2 hand views, so they're not even wrist views, and these were not done for QME evaluation. And so you can look at the scapholunate interval here, and you know what, we don't even have a lateral view here. I'm not sure why. So I'll just show you the scapholunate gap. Let me blow it up here a little bit more. And you can tell already here, where am I going to measure from? Well, you measure from the middle is how you do it, right? If you measure too distally, this measure is not even a millimeter, 9.5, or I guess almost a millimeter, 0.948 millimeters. so that if you use that, oh, it's normal. I gotta click up here again, but if you measure to proximal, right at the proximal articular surface, oh, that's 8.3 millimeters. You're probably gonna overcall carpal instability patterns. But really, you should be measuring, right at about the midpoint when you have, kind of incongruent or non-parallel articular surfaces. But I think you get this when the positioning is a little bit off. Oops. Let go of the thing there. Let's so here right through the midpoint here, then I get about 3.7 millimeters, and that's abnormal. So anything above 3 millimeters is the AMA guides cutoff that qualifies for upper extremity impairment. So let me close this, and let me go to open up a couple other studies that I have here. Where are they here? So let's do this one right here. So here's one. I think I should have a lateral view here. Yes, I do. So I'm going to pull up the P to A and the lateral here. Let's flip them around so it's a little bit easier to look at. So here you can see these were not done for QME evaluation either. This was just done P to A, non-clenched fist, and you can see it's a little bit, even here it's a little bit hard to measure the scapholunate gap, right? Where is the radial side articular surface of the lunate? I would probably measure from about here. It looks like there's a subtle hint of a cortex of the articular surface. So if you measure this, oh, okay, oops, it measured about 1.3 millimeters. Okay, that's probably normal. So let's get rid of that. So let's go to the lateral view here to see and where we draw these lines. And this, immediately when you look at this, it looks abnormal, right? Look at this, the dorsal tilting of the lunate. That's got to be abnormal. Look at this pisiform. Why is it so anterior or so volar? Is the triquetral or piezotriquetral joint too big? Maybe there's an effusion in there. And there might be, but this is also poor positioning. We see this, well, I don't know, I see it pretty frequently in my practice. One way to tell if your lateral view is done properly is that the anterior tubercle of the scaphoid, which is right here, this should be anterior more, and it should overlap at least 50% with the pisiform. And it's not here. So this is supinated a little bit too much. So the three lines, again, are the long axis of the radius line. So basically you just draw a line through the long axis, and you kind of want to make the line right in between the two cortices, anterior and posterior cortices. We can ignore this number here because I'm just using the number line or the linear measurement tool. Next line is through the long axis of the scaphoid. So here again is a scaphoid. Here's the anterior tubercle. And if you zoom in here, you can kind of see the articular surface of the scaphoid, right? The articular surface of the scaphoid is going to be more distal than the proximal articular surface of the lunate, right? Because the scaphoid sits a little bit higher. We could see on the P to A view, right? It should, with this normal inclination of the distal articular surface. So this is the lunate articular surface, or the bowl is what I like to call it. And this is the articular surface of the scaphoid. So we draw a line from here, the anterior tubercle, and parallels the anterior surface of the scaphoid. The lunate is a little more involved. You can kind of just eyeball it yourself, but sometimes, it's a little bit hard to do it. But what you want to do first is to draw a line between the anterior rim of the bowl and have it intersect with the posterior rim of the bowl. And here, the posterior rim of the bowl is not really well seen. So I would just follow the contour. You can see it goes right to about here. In this case, it actually perfectly overlaps the ulnar styloid process. So the ulnar styloid and the posterior rim of the lunate bowl is there. So I would draw it from here, anterior rim of the bowl, and intersects with the posterior rim of the bowl, which incidentally or coincidentally in this case is also the radial styloid. So that's the not the long axis of the lunate. What you want to do is you want to draw a line that's perpendicular right? So I just eyeball this. This looks not quite right. This is not quite right the other way. Let's go in between. Okay, so it's right about there. So let's get rid of all these numbers. We can get rid of this measurement. And so we should be left with 3 lines here. And so you really just want to measure the angles between these 3 lines. And you can use the angle measurement, A, or the, what's the other one? That was the Cobb angle, which I think is C, right? So here is C. This is the keyboard shortcut for Cobb, and A is a keyboard shortcut for angle. And you can use either one. Let's use angle since we didn't use that one before when we did the angular instability measurements for the cervical spine. So let's do, the first one we do is the radiolunate angle. So the angle between the radius long axis and the lunate long axis. So let's just measure that. So this is approximately parallel to the radius. Normally I do it a little bit closer. Well, look at that. We can, well, too late. So let's, 2 lines, one parallel to the radius axis and one parallel to the lunate long axis, and I get 31 degrees. So that's definitely abnormal, right? You need, I think it's more than 10 degrees to call it normal, to call it abnormal, and greater than 30 is a severe carpal instability and severe upper extremity impairment. So radiolunate, 31.7 degrees, and then the next one we measure is the radiolunate angle. So this is the angle between the radius and the, or sorry, not the radiolunate, the radioscaphoid, scaphoid lunate angle. So that's between long axis of the scaphoid, which is this one, now yellow, and the lunate, which is this now yellow line. So again, just parallel line here, and then parallel line here, and we get 50 degrees. So which is normal. You need at least 61 degrees in this angle to be abnormal and to have a, if that's the only thing, to have a carpal instability pattern to qualify for upper extremity impairment. So let's go back to the table here to make sure. So we just did radiolunate angle and we got 31 degrees, I think, right? So that's definitely abnormal here. It's greater than 30 degrees, qualifies for severe upper extremity impairment, 25% of upper extremity impairment. Our scapholunate angle was in the 50s, so that's normal, less than 61 degrees. I think I have one more case here just to practice. So let's see what we have here with this one. Let's open this one to see what we have. Oh, this was actually a chiropractor that fell skiing, and she actually hurt her hamate, and we thought it was, or she thought it was fractured, but I don't think it is. So here are the 2 views here, and these were not done with a clenched fist, and these were not done for QME evaluation, but it's not a bad exam, right? You can kind of see this normal, or not normal, but that's, if you don't do the pronated positioning on the P to A view, that's what you get. And it does look wide, right? And so, but it's not wide enough for permanent impairment. So if you even measure here at the midpoint, you get about, that's right on the cusp, 1.5 millimeters. So I told her I think it's wide, and I would be, she didn't have any pain there, for her, because she's a chiropractor, I said, let's make absolutely sure you don't have a tear there, because that could be, career threatening. On the lateral view, this is a little bit hard sometimes if we don't, so here's the normal nice lateral view where there's an overlap between the pisiform and the anterior tubercle of the scaphoid. So if we draw a line here to here, and again, which curved line is the scaphoid? Well, it's the more distal one, because the scaphoid sits higher than the lunate typically. Here's a lunate right here, the bowl. And here you can't, it's really hard to make out, but I think you can kind of follow the capitate. So here's a proximal border of the capitate. If you can find another line that's roughly curvilinear and parallel to it, that's probably the bowl of the lunate. So here's probably the anterior lip of the lunate. If you follow those posterior contour lines, it's probably right about here. And then so we draw this line that's perpendicular to it. And then that's our long axis of the lunate. And of course, the radius is super easy. We just draw a line like that. Let's just draw it super long so it'd be easy to take our measurements. So we have all these lines, again, the radius, the scaphoid, and the lunate long axis, and you just measure the angles in between those. So it's not that hard. It's just those three key lines. Oh, I forgot there's those other two measurements that we need to do. And those, the triquetral lunate step-off and the ulnar translation, I've never seen these. They're relatively rare, at least in my practice. We have not seen one, not that I know of that we've seen one. And so I just have a couple examples here that are taken from the literature. And we can't measure off these, but you can see there's obvious alignment change here in the proximal carpal row between the lunate and the triquetrum. This person had apparently a severe injury. You can see, widening of the distal radial ulnar joint. And for the astute, you can see that this is actually a lunate dislocation. We don't see the two parallel lines here of the articular surface between the lunate and the capitate. So this is actually a volar, I don't have the lateral view, but it's a volar dislocation of the lunate. There's triquetral lunate dissociation because there's proximal migration of the triquetrum, and there's a distal radial ulnar joint injury. And I bet there's going to be a triangular fibrocartilage complex tear as well. So that, I've never seen that before in practice. This is someone with ulnar translation. And, I don't really like this term ulnar translation because that's what it is, but it's really referring to the lunate and how the lunate translates ulnarly in the ulnar direction. So if you look at this, this is actually normal ulnar translation of the lunate. Although it's dislocated, there's no ulnar translation. The proximal articular surface of the lunate overlaps with the radius at least 50%. This is, I'd say probably about 75%. So that's normal ulnar translation. Here you can see there's only 25% overlap between the radius and the ulna. So this is a severe ulnar translation. And, these can be due to trauma or more specifically in this case, if you notice there are multiple black dots here or black spots or the so-called spotty carpal sign. There's probably one down here as well. There's probably more, but we just don't see them on plain radiographs. And if you recall, this is the most common cause for this appearance is rheumatoid arthritis. So those are fairly rare. I've never seen that. Well, actually, I have seen this pattern. We don't, we see rheumatoid arthritis not uncommonly, but the severe cases is a fairly severe case. We don't see that very often. But the triquetral lunate step-off, I don't think I've ever seen that in clinical practice. All right, well, now we're on our last section, chapter 17, lower extremities, and we're going to concentrate on the knee. Subsection 17.2H is on arthritis, and this is what it says. Certain röntgenographic findings that are of diagnostic importance, such as osteophytes and reactive sclerosis, have no direct bearing on impairment. So, sometimes we see these findings on the X-ray, and we know that it's abnormal, but they actually have no effect on our impairment ratings. It goes on to say that the best röntgenographic indicator of disease stage and impairment for a person with arthritis is the cartilage interval or joint space. The hallmark for all types of arthritis is thinning of the articular cartilage. This correlates well with disease progression. So that's a very easy a very easy measurement to take on X-ray, right? The X-rays are generally pretty easy to do. I think it's a lot easier than taking the spine radiographs that we had in chapters 15. And actually in this section, just like in the rest section, they say specifically how to take these X-rays of the knee. And I think everyone knows, but X-rays of the knee, if you have your own X-ray in your office, they should be taken standing. And typically you want to tilt the tube up just a little bit to parallel with the joint spaces. You don't have to do it. It also, projects the patella a little bit out of the way, but it makes it a little bit easier to measure the joint space, at least in the knee. They even go so far as to say your focal film distance. So that's the distance from the tube to your bucky or your DR plate. Should be 36 inches, which is a little unusual. Usually it's 40 inches. I don't know why they use 36. It must have been from some study. I didn't mention this in chapter 15 of the spine, but of course, if you're taking your own x-rays, you want them to be in maximal amount of flexion and maximal amount of extension in the cervical spine. Same within the lumbar spine. We didn't cover that. And a good way to do that in the cervical spine is to have them tuck their chin in first to get the upper cervical flexion and then look all the way down. And that way they'll get full flexion, and it's almost like a provocative exam because they have any type of injury back there. It should cause at least a little bit of discomfort, if not pain, and hopefully they can hold it for half a second to a second while you take the x-ray. So the next slide here shows the table that's in this subsection, table 1731, showing arthritis impairments based on these measurements that we take of the joint spaces. And of course, it's not a space, right? Anatomically, we know it's filled with cartilage, and cartilage is just radiolucent, so it looks like a space on the x-ray. And so you can see here, that's down on this first column, you can see all the joints with the normal measurements in brackets or parentheses, and the impairment ratings based on the measurements of those joint spaces. We're going to focus on the knee just because that's I feel like it's probably the most common one, at least the most common one that we do. And in the knee, it's very easy. You're just looking at the tibiofemoral joint space, and it should be 4 millimeters or more. If it's less, then if it's 3 millimeters, then it's 3 millimeters whole person or 7% lower extremity impairment rating. Pretty simple to do. The patellofemoral measurement is done on a tangential view, and we learned in school as a sunrise view. I don't know why we taught it that way, I was taught that way too, and that's with the knee in full flexion. But that you can really only do on if you have a table, and so in the AMA guides, they say actually to do the tangential view, which is with the knee in 40 degrees of flexion. Of course, not an issue if you're sending your films out, but if you're taking your own radiographs, then if you use the right technique, I think it is a more sensitive exam. So here is bilateral knees done in the standing position, but they just took it straight, so you can see through the joint spaces pretty well. And actually, this is not in the program. Let me toggle over to the program here. So here you can see through the joint spaces pretty well, but here it looks like it's bone on bone, but it's not, right? It's just because the tibial plateau on the medial side is different from the lateral. And you can see it here as well on the other side, not to the same extent. And that's because the medial tibial plateau tends to slope forward. And so if you do that 15-degree tube tilt, 10 to 15 degrees, well, actually, I think maybe it's 5 to 10 degrees of cephalad tube tilt to match or to parallel with the medial joint space. It's a little bit better. So if you go ahead and measure these, and where do you want to measure from? It's such a big joint space. Well, generally you want to measure from the lowest point of the convexity, and you want to measure down to the more dense cortical line. So that's about there. So about 4.5 millimeters. So it's normal, right? Anything 4 millimeters or more is normal. And here, from the lowest portion of the convexity down to the cortical line here, we just barely make it, 4.2 millimeters, 4.3 millimeters. Here, this one looks huge, so I know that's definitely going to be normal. Here we're at 5.4 millimeters. And here we know this is probably going to be abnormal. And so here, it's really hard to see the anterior border here at the lowest point, but I would measure it probably from about here to here. Wow, it's not even 2 millimeters. So this is definitely an impairment rating less than 2 millimeters. I don't know the exact percentage, but we'll look at the table when we finish our measurements here. So let's put this up here, and we'll look at the tangential views. So I'll just split up like this, just so we have it here. You can measure them on the lateral view, but I prefer measuring them on the tangential views. So here you can see nice, juicy patellofemoral joint spaces. You already know these are going to be normal. And incidentally, you'll notice that there's a ossification of the lateral retinaculum, or it could be an osteophyte. It looks more like an ossification, though it doesn't look like it's connected because you can see a cortical border all the way around. Plus, osteophytes tend to be, pointy on one end. So, where do you measure these? Like this one looks pretty easy to measure. So you want to measure at a right angle, of course, just like all the other ones. This is probably a little bit too high. But here there are, 3 contours here, which is, pretty common for the lateral facet. It looks like that. Actually not here, but one of them usually has kind of at least 2 or 3 contours, and basically you want to measure from the most dense cortical surface. So you want to measure from up there down to here, and that's normal, about 6.3 millimeters. And over here, relatively easy. You see the 2 contours, but I would just use the more dense one. And again, at right angles from that down to the femoral condyle. These already we know are going to be normal, more than 4 millimeters. So 4.9 there, 6.5 there, and 6 millimeters and 6.3 on the other side. Like I said, you could do it on the lateral, but I prefer the tangential view. Sometimes it's really hard to tell which side is which. Generally speaking, you want to measure from these. So this is the this is the lateral femoral anterior surface of the lateral femoral condyle. How do I know it's a lateral femoral condyle? Well, because the medial one is usually the bigger condyle. So this is the medial one, and this one you want to measure to the more dense one because that's the medial facet. And this actually looks abnormal if it's 3.4 millimeters. But I think this one is a little rotated, and that's why this measurement looks like it's too big. I mean, I don't know if I've ever seen one that's 8.5 millimeters. So I feel like it's a little bit unreliable to measure the patellofemoral joint spaces on the lateral view. I prefer the tangential view, as you can see here. And these, again, they're done at a 40-degree angle and with the beam at tangential or parallel to the patellofemoral joint space. So these, let's go back to the table here just to see what happened to it. Let's go back to the table here. So, our knee joint, what did it measure as? 1.6 millimeters, so that's pretty bad. So tibiofemoral joint space, so that's 2 millimeters. So that equates to 8% whole person, or 8% whole person, or 20% lower extremity impairment rating. And of course, the patellofemoral joint space was normal. So in summary, I hope you guys learned something from this. Remember, in your report, you should be looking at these images and providing your opinion and whether you agree or disagree with the primary report. I hope you have a viewer that you use. If you have one already, I hope you can use the same one for viewing all the images, including outside imaging. If you don't have a nice, consistent viewer, I highly recommend that Radiant viewer. It just saves so much time and just makes the process much more efficient. Hopefully you're a little bit more familiar with some of these x-ray measurements, spinal motion segment integrity, and we just did cervical spine, but the numbers are just a little bit different for the lumbar spine, but the measurement technique is the same. Carpal instability in measuring the angles and the intervals. Remember, there's those 3 key long axis lines that you have to draw through the radius, the scaphoid, and the lunate. And lastly, that we just covered specifically for the knee, but in the lower extremity, it's fairly easy. You're just measuring joint spaces for post-traumatic arthritis. Here's an example of an x-ray just for shock value. It's a real x-ray of someone's high heel through another person's eye, 2 different people. It was actually published in the Canadian Journal of Anesthesia, and hopefully you never see it. I think everyone knows this, and I know Dr. Carpenter mentions this too in his lectures, is that these findings are just a small part of your report, and and may or may not contribute to the patient's symptoms or even to their impairment rating. And you have to use your expertise and your experience in this matter to come up with the final rating. So hopefully you enjoy this. If you have any questions, you can contact me at any time, and I'll be here for a few more minutes with Dr. Carpenter to answer any questions you may have. Thank you very much.